Welcome everybody. Thank you very much for joining us for our IBMS Support Hub in November. I'm delighted to be joined as always by Tamina, who's presenting some of the slides today, and also by Ian, who is a programme lead from the university. You've just changed your university, Staffordshire. I'm not sure which way round.
Just changed from Staffordshire University to the University of Staffordshire. So
perfect.
A masterpiece of marketing, having that.
Indeed,
that
flip those words. Thank you again for joining us today, Ian. We've got a really interesting session today about interprofessional education and learning. So thank you again for joining us. I will do the first few introductory slides and then hand over to Tamina. So welcome to the session. I hope that you find it useful and enjoyable, whether you're in practice, whether you're a student, or whether you're in an academic position. So what we're going to do in the session, as I say, the microphones are muted at the moment and cameras are turned off. But once we get started, I will manually change that setting. So if you do want to unmute and ask a question at the end, please do. In the meantime, if you'd like to pop any questions into the chat or the Q&A, we can answer those as we go along, or we can take the question at the end if that's easier to have a discussion. So the title of the session is Interprofessional Education: How can multidisciplinary teams learn from each other and improve collaboration and patient care? So next slide, please, Tamina. So I'm going to start the session just by talking a little bit about interprofessional education, what we mean by that, what the definition is from the World Health Organization, and then how we use that when we look at accrediting degree programs. So the definition from the WHO is interprofessional education occurs when two or more professionals learn about, from, and with each other through collaboration to improve health outcomes. So, and that's very much the theme for today. It's not about, Ian's just said, all taking, it's about giving, isn't it, Ian? So it's about a really nice organic relationship between people who are in the profession, in academia, and our students and apprentices, and how they can learn from each other and improve that patient outcome. So from the Institute's point of view, the way that we use interprofessional education and the way that we get our accreditation criteria together is by using something called the Subject Benchmark Statement from the QAA. So the QAA is an organisation in the UK, the Quality Assurance Agency, and their role is to look at provision in higher education institutions. They're an independent charity, and what they do is they enhance quality and ensure standards in the taught provision in all of our UK universities. The QAA creates subject benchmark statements for every subject that will be taught in a higher education institution. So we have one which is for biomedical science and biomedical sciences. The current benchmark statement was actually rewritten in 2023, so it's been updated recently, and we made a real concerted effort to make it clear the difference between an IBMS accredited programme, which is biomedical science singular, and a non-accredited programme, which is biomedical sciences plural, so that people are really clear about what the differences are and what the content is that they might expect in each of those versions of a programme. So on the bottom of this slide, we can share the slides after the session. I've put a link into the subject benchmark statement currently, which is in use, and it's what we refer to when we are accrediting our BSc and MSc programmes. Next slide, please, Tamina. So what we do when we have a benchmark statement review is the QAA will put out a call and they will ask for people from practice and from academia to come forwards and be part of that review panel. Every time the subject benchmark statement for biomedical science and biomedical sciences has been written, the Institute has had representation. So I was on the QAA benchmark statement for 2023. And prior to that, Alan Wainwright was in every one of the review panels as well, to ensure that the Institute was inputting into the information. And we could also have really clear, informed perspectives from people who are working at universities and also working in practice to make sure the information is current and relevant and useful to people who want to work as a biomedical scientist after graduation. The way that we use the benchmark statements at the Institute is we use them to write our accreditation criteria and our guidance documents for programme development for both masters and undergraduate programmes. And in the accreditation criteria, we have guidelines around the curriculum that needs to be included, what the content of the programme needs to be, the clinical specialisms, basic knowledge, and also things that wrap around that. So the assessment strategies, authentic use of assessment, and also the skill development that students must meet as they go through a programme. So we use the benchmark statement to inform our updates to the accreditation criteria, and that hopefully should give you a really nice holistic package for each of the programmes which is being taught that has IBMS accreditation. Next slide, please. So when we use the benchmark statement, as I've said, the subject benchmark statement has really detailed information about clinical specialisms and about basic knowledge as well. So they're the talk components we expect to see. But in addition to that, it also has some requirements around an integrated module, which is where you would study pathophysiology, bringing all the clinical specialisms together, thinking about them in a really nice integrated way. And we also have some information around the degree programmes having interdisciplinary learning and teaching. So we're looking that those programmes have students working with others as you would do in practice. So their HCPC standards of education and training talk about service users, and they also talk about interdisciplinary learning. So as part of the accreditation criteria from the Institute, we have criteria that our programme teams need to meet to explain to us where they have interdisciplinary teaching. And then the last slide that I'm going to present before I hand over to Tamina is just explaining that in a little bit more detail. So what we are asking in the subject benchmark statement and in the Institute's accreditation criteria is to look at the relationships and the interfaces between students who are studying biomedical science or other subjects that are aligned to biomedical science or the non-IBMS accredited biomedical sciences, and allowing them to interact in a multidisciplinary environment, partly to get them ready for employment and also to give them a much more rounded set of information about the way that their work interacts with people from other professions. So a lot of universities that offer biomedical science programs quite often have allied health programs. So they'll have physio, occupational therapy, some universities have nursing, and some universities have medical schools. So it's about looking at, can we get the students from biomedical science programs interacting with students from other programs in a really useful and informative way? So it helps both of those sets of students with their practice and with their knowledge and understanding. And also, we want to be the program teams to be able to explain to us and evaluate the contribution of the biomedical science students when they are doing that interdisciplinary learning. What kind of challenges do they give them? What are they learning? How are they broadening their thinking and having a much better holistic view of the service user and the patients when they're thinking about how those samples are being tested, what it means for the patient, diagnosis, prognosis and treatment. So just having a really nice holistic overview by working with students from other different courses, which will really help them have a much more rounded education. So over to you, Tamina. I will mute and turn off my camera and I'll be in the background answering questions if necessary.
Thank you, Sue. I'm just going to ask Ian to come in here because I think he wanted to talk a little bit about the HCPC standards of education and training in a little bit of detail.
Yeah, absolutely. Just a couple of slides from me, and it just picks up on what Sue's just said. So Sue mentioned about the standard of education and training. And these are integral to anyone who delivers a program that is eligible for HCPC registration afterwards. It sort of guides how we set the program together, the requirements we have to the HCPC. And it's not just individual universities. This applies to the Institute. The Institute portfolio, the registration portfolio, is the HCPC approved education route for biomedical scientists. And so this standard of education and training underpins all of those accreditation criteria that Sue mentioned. And the important one for this is the SET, Standard of Education and Training 4.9. And that's really clear in what it sets out. And it says that the programme must ensure that learners are able to learn with and from professionals and learners in other relevant professions. Now, obviously, the HCPC standards of education and training apply to all the registrable professions. So all of the professions that can enter the register, paramedics, the physios, all of those have to follow the same standard. And the important part there is that with and from. So it's not just as from a HCPC point of view, learning alongside just seeing what other professions are doing. It's a two-way process. It's seeing how we can learn from other professions can learn from us. So all of the examples that we will give throughout this talk, and Tamina will talk of examples that she uses at Salford, I'll talk about a couple that we use at the University of Staffordshire, are all designed to have that cross-pollination between disciplines. And that's a really important part of this. It's not just going along and seeing something in a different department. It's how we both learn in our different ways from that. And so hopefully as you go through these and see the different examples, that will become a little bit clearer. Thanks, Tamina.
Thank you, Ian. So yeah, now that we've talked a little bit about what interprofessional education is and how we can learn from each other, I'm just going to quickly give an overview on the benefits of interprofessional education, which you'll all be aware of, but I think it's kind of, we don't really think when we're working in a lab, so in practice, how we can work with other teams a little bit better. So the benefits of interprofessional education, obviously we know in healthcare that teamwork is really important. Patient care often requires input from a variety of specialists, whether that's doctors, nurses, biomedical scientists, pharmacists, support workers, lots of different roles that are involved, which we will talk about later on in a case study. But just working more effectively with each other is really important. You know, it really improves that teamwork and relationships between the different professions. And it allows us to work more seamlessly together in clinical settings. I think one of the biggest challenges in the healthcare is kind of the misunderstanding or misinterpreting the roles of other professionals. So, for example, a doctor might not fully understand the role of a biomedical scientist in diagnostics, or a nurse might not know the full extent of a pharmacist's role or expertise in managing medication and the side effects. So, I think interprofessional education really addresses this by educating each profession on what everyone contributes, and it leads to mutual respect, fewer conflicts, smoother workflow. And I think it's also really important to understand that no role is more important than the other. I think we're all there working best for the patient outcome, really. So when professionals understand each other's roles, they can work together more effectively, consult each other more confidently, make better informed decisions on behalf of the patients. And one of the biggest benefits as well, I think, of interprofessional education is knowledge exchange. It allows not only just those of us who are in practice, but also students to learn from each other's specialist knowledge, which they might not be exposed to otherwise. So, for example, our students on the biomedical science programme, if we're not exposing them to other roles, then they're not going to be aware of what nursing students do, for example. Interprofessional education also looks at communication, which is a priority. It's a critical skill for healthcare professionals. So by participating in interprofessional exercises and learning, we can teach future healthcare professionals how to communicate clearly, share information effectively, and it also encourages people to ask the right questions across disciplines. So it not only helps to build confidence in our own skills, but also our ability to work alongside others. And ultimately, interprofessional education is designed to improve patient outcomes, and that's our goal within healthcare. So we want to work together to be able to diagnose, treat, and support patients more effectively by collaborating better and leading to more faster and accurate diagnosis. And also allowing the patients to have more of a positive experience as well. So just to kind of talk to you about how we can incorporate interprofessional education in practice, but also in education. I've taken this from the Manchester NHS Foundation Trust site, and I found a really useful kind of mapping document. So you can see in the middle here, we've got service user right in the middle. So this would be our patient. But then each of these areas would be the services that the patient uses. So we could put a department in each of these and look into their role and the services that they provide. And then on the bottom here, you can see an image, which is kind of a timeline of the patient's journey. So from the point that they're admitted and, you know, the patient presentation, the symptoms, who's involved at which stage, and using this to kind of look at the roles that are involved in patient care. And we can use this to then integrate into professional education within training programs, whether that's in the workplace or in higher education. So to start off with, if we're looking at putting a training program together and we're interested in incorporating into professional education, we could look at joint seminars, a really good way for students to come together from different disciplines, learn from different topics, discuss issues that affect all the healthcare professionals. So for example, a seminar on infection control or patient safety is relevant to doctors, nurses, biomedical scientists, and pharmacists. So by learning side by side, everyone can gain an insight into how each of those professions addresses challenges. So that helps to kind of promote respect and understanding of each other's roles. It also helps students to kind of build a network as well and professional connections that can help better collaborations in their future careers. You can look at team-based simulations as well. So Ian and I will talk a little bit more about how we do this at university. But I've met a few people in the last year who have started to use simulations within the workplace as well. And, you know, we've worked together to develop ideas. So simulations are where you're trying to mimic real life healthcare scenarios. So professionals from different disciplines can work together to solve patient cases or respond to emergencies. And these are really, they're a powerful tool in the workplace because they allow people to practice those roles in a controlled and safe environment. It's a safe environment to make mistakes, but learn from them and reflect. But students get an opportunity to communicate with each other under pressure and practice their roles under high pressure. So it actually allows them to develop their confidence in these situations. I know many of you who are in practice supporting students completing their portfolio encourage students to attend multidisciplinary team meetings. Not everyone is able to do this, but again, it's a really useful way of giving students a first-hand look at how various professionals come together to discuss patient care. So we have representatives from various disciplines to review these cases for patients and then make a decision collaboratively. So allowing students to attend these meetings and observe, you know, what's discussed in these meetings gives them kind of a value, you know, it shows the value of input from every team member, and it reinforces that kind of shared decision making when it comes to patient care. Again, arranging students to visit other areas within a trust, and not just students. When we say students, we can also arrange for colleagues who are already practicing, but allowing them to visit areas within the trust. Examples can be visiting outpatient clinics, the wards, the theatres, those kind of areas, and giving an opportunity to gain a new perspective on how diagnostic work in other areas can impact patients. And also allows us to see how clinicians work in different care settings as well. And then looking at leadership support. So I think, again, it's really important that departmental managers promote a culture of collaboration. So allowing multidisciplinary team meetings. So I remember when I was working in the labs, we had sometimes some emergency scenarios where we would provide blood to a different site in emergency settings. And of course, you learn from these scenarios, some things that we didn't have in place, we've put in place as a result of those kind of situations. But our departmental manager allowed us to work together with the nurses, transfusion practitioners, to again attend a multidisciplinary team meeting, and we were able to discuss what went well, what didn't work so well. So kind of an opportunity to reflect. But again, I think leadership support is really important for these kind of things to take place and to encourage these examples of practice as well. So to give you an example of how we might do this, put together a short case study on how different professionals work together to provide the best patient outcome, really. So we've got here a patient who is a 67-year-old male, and he recently went through a knee replacement surgery. Initially, he was recovering really well, but on the 5th day after surgery, he started to develop some symptoms, including high temperature, so fever, as well as chills and mild confusion. His heart rate was increasing rapidly, and he had a high white cell count. So initially, when he first presented these symptoms, the concern was that he would probably have a post-surgical infection. So through patient assessment, the nurse kind of noted down the patient's temperature, did the routine checks, checked his symptoms, and contacted the doctor, which again involved a clinical assessment. So the doctor examined the patient, looked at the various sources of infection, which might be the surgical site, the urinary tract, or the respiratory system. And after a physical examination, some blood tests were requested, as well as urine cultures, along with wound swabs and some imaging tests, all to determine where the infection was coming from. So we've mentioned the blood tests and cultures. So of course, these get sent to the pathology lab, and a biomedical scientist would process these samples. So of course, again, we would involve MLAs, support workers, when it comes to specimen reception, checking those samples, preparing them before they're tested. But then a biomedical scientist would process these samples, and the cultures indicated Staphylococcus aureus, which indicated a post-surgical infection. Upon antibiotic testing, it showed that the strain is methicillin resistant, so MRSA, can't get my words right. So they communicated these results to the healthcare team to look at designing a targeted treatment plan. But we also mentioned that the doctor requested some imaging tests, so that involves a radiographer who then performed an MRI to check whether the infection was spreading to the surrounding tissues and whether there was any internal complications such as abscess. This also involved a pharmacist reviewing the patient to check for any potential drug interactions as well, who then helps a physician to select a safe and effective antibiotic regimen, who recommended vancomycin and also discussed how to manage any possible side effects. The process also involved an infection control specialist to look at implementing precautions, including isolation measures for the patient, as well as infection control protocols for staff. And this was really important in preventing the spread of resistant bacteria. There was also a physiotherapist involved, looking at the sort of exercises for the patient, because as the infection began to clear, the patient was experiencing some stiffness and reduced mobility in the knee that was affected. So the physiotherapist recommended an exercise regimen to support the patient's recovery and help him regain movement, and worked closely with the nurse and doctor to try and tailor those exercises to try and prevent aggravating the surgical site, but also allowing mobility. We also had the occupational therapist involved, who observed that the patient had difficulty in performing daily tasks due to reduced mobility and mild confusion. So again, the occupational therapist had to assess the patient's needs and provide adaptive equipment to help recovery at home, which also involved a home visit to ensure that the patient has a safe environment when they're discharged. So the patient also started to develop kind of stress and showed signs of anxiety because of the prolonged hospital stay and experiencing the stress of infection. So the clinical psychologist, again, the role really important when we're looking at emotional support and helping the patient manage stress and worry when it comes to recovery. Again, really important when when we're looking at addressing the mental health aspect, which sometimes can be overlooked in physical health recovery. We also have social workers involved, assessing the patient's living situation, looking at how they can connect the patient with the community and allowing services to be provided to help the patient recover. So again, arranging in-home support or looking at kind of the transport for follow-up visits, making sure the patient has everything he needs to recover well from the surgery and the infection. But also other areas that we might not think about as well necessarily, especially when we're working in a lab and we're quite hidden, working behind the scenes. We don't often think about a dietitian, who again is really important because they need to be able to recommend a diet that supports the patient with their healing process. So checking that the patient has an adequate protein intake, the vitamins and minerals that they need to recover, but also looking at any kind of food that the patient might be allergic to or might also react because of the medications. So it's kind of tailoring the patient's diet accordingly. And then a role, which again, I wasn't familiar with until I kind of looked into this case study in a bit more detail. So patient navigator, and they're usually responsible for reviewing the discharge plan, making sure that the patient actually understands their medication, making sure that they understand the physical therapy, that they will keep up with their exercises, and they also know about their follow-up appointments. So their role, again, is serving as a point of contact for any questions or concerns that the patient might have once they've been discharged and they've gone home. So quite a few roles involved in the patient care, which we might not necessarily be aware of. But again, just to summarise how that has really helped in this scenario. So again, it's enhancing team-based care. We can see how a coordinated interprofessional team approach leads to a thorough and effective patient care outcome, and how each professional has contributed to a well-rounded approach. So they've all given their unique expertise in each of these at each stage of the process, which helps with not only the physical recovery, but also psychological recovery. But again, helping to kind of develop that communication process and awareness of each of the roles. So by us understanding each other's roles, we know who to consult for different aspects of the patient's care. And we can look at all dimensions, so not just the physical aspect, but emotional, social, and dietary aspects are combined as well. And this leads to a more positive patient outcome. So hopefully that improves kind of the patient's experience, because again, you know, you hear of different stories where patients have gone in, they're not quite sure who they're speaking to, who they need to address some of the questions to. So by having an approach like this, it will help the patient also understand who they need to speak to, but also us as professionals. So myself as a biomedical scientist, just knowing which direction I can point the patient to, for them to get the information that they need really helps. So how do we do this in higher education in a university setting? So you can see a couple of images on the slide here. We've got on the left in the lab, these are our technicians and students working in the lab, and you can see the monitor, and this is being live streamed. So we have in one of our modules a process where we have some patients or dummies in the simulation suite that the nurses work with, and they're bleeding patients. So they're actually taking samples, and our students are observing this on these monitors in the lab. So they can see how samples are collected by nurses and how they're being labelled up. And they're observing that process, so kind of looking at the patient identification and how, you know, all the forms and samples need to be labelled up. Those samples are then sent to the lab for processing. So you can see on this right image here, our patients are processing the samples, and these are particularly blood transfusion samples, so doing blood grouping and antibody screening. And again, our nurses are able to observe this process through live streaming on the monitors in the simulation suite, so they can see what happens when the samples arrive in our labs and what we do as biomedical scientists. So they observe that process. And then ultimately, when we process the samples and need to provide blood, so red blood cells and platelets, you can see in this image here, we prepare those blood products, and then we ask the students to issue those products to the patients, so nurses can actually transfuse them. So you can see in this scenario here, samples have been processed, and we've got units of blood and platelets, FFP, ready to be issued. But what we did in this scenario was we actually created a simulation where we had a massive hemorrhage scenario. So a patient was bleeding to death, and a nurse called the lab and said, we need blood urgently. And then we got our students to prepare that blood. Now you might notice here in this picture, we've got a unit of blood that looks like it's got blood all over it, basically, which it has because it was leaking. So in that situation, we got the students to think about what they would do under pressure, look at what blood products are available and what they would actually issue to the patient. And then you can see in this image here that the nurses have already collected the blood, and then they're checking it against the patient's details before they're actually transfusing the patient. So that is an example of something that we do at university in one of our practicals. It gets the students working with the nurses, gets them communicating with each other. So initially what we did was had the process being live streamed on the screens. Students were able to observe each other, whether they were nurses or biomedical science students. But at the end of that, we actually got the nurses coming into the biomedical science labs and got the students talking to each other and reflecting on that process. And, you know, they gave us some really good feedback, how they've really enjoyed working together, and it's made them understand what happens to the samples when they are first being collected, and then what happens on the other end when they arrive in the lab and how they're being processed. And I know Ian's got some examples that he would like to share as well.
Yes, so a similar thing really. So talking about some of the things that we do at University of Staffordshire, which are very similar in a way, but it is all about collaboration. So at the top left of the screen there, we've got some of our healthcare science apprentices who are working in the simulation ward. And what they do there, the simulation team and some of the practitioners and some of the students from our health courses will be running a number of situations. We'll have a patient in a cardiac arrest. We'll have possibly a major hemorrhage, a variety of sort of high stress, high stakes situations, and they will be carrying on their simulation. They'll be acting it through. They'll be probably throwing in a few deliberate errors. They will maybe take a few shortcuts with sample collection. And our students sort of sit within that almost like a goldfish bowl, sort of looking at what's happening and making notes and intervening to stop when they see something happening. But also it gives them an idea of the high stakes and the high pressure that's happening at the other end of the telephone line. So when they're in the lab and they're getting phone calls from A&E or from a acute care ward, desperate for results, they can see what's happening at the other side. So that's quite effective. The top right there, we are going through some phlebotomy simulation. So this is led often by a paramedic team. We'll go through that. We'll have some service users as well in that room, so they can talk about their lived experience of having regular samples collected. Again, some sources of error we might throw in there. We'll talk about different types of sample. We'll do phlebotomy. We will do some MSU collections. We'll do a variety of different things, again, just so they can see the whole journey and feedback. We look at a few different things as well. So at the bottom left, we bring in speakers. So that's Jane Mills, actually, from NHS England, talking about sort of leadership roles in pathology. So we're looking at also how we can influence up and out of the profession itself. And I said right at the start that it was important that any interprofessional education is a two-way process. It's not just us seeing what other people do. It's sort of both aspects as well. And Tamina demonstrated that on the previous one. So the bottom right there, those who are lovely pink lab coats, they always get a nice comment of the pink lab coats. That's a mixture of our apprentices and student nurses. So the reciprocal arrangement is the student nurses will come into the lab whilst we're doing blood films and a bit of blood typing. They'll join in with those apprentices. They'll sit next to them. They'll be using the microscope. They'll be looking at cells under the microscope. They'll be doing some brief cell counting. But again, it shows just the range of things that you can do when you get two people together. At the best, what happens is they start talking. They have a laugh and a joke. They talk about experiences of their placement. So all of these are student nurses who are either on clinical placement in various different settings or apprentices who are working in practice. So it gets a conversation started and some really interesting learning going on there. Next slide, please, Tamina. So another thing that we do is sort of generate content. So we will get students to think about current and present issues from their workplaces. So we will get them to working groups, have a think, talk to their colleagues, look at maybe their quality management systems, look at the number of incidents from a particular place, whatever it might be, to generate an idea of things to sort of develop an idea. So it could be, and there's two examples there. The one example was an increase in transfusion-related errors on request forms, and the other was just general errors in sample collection. So students work together, they put these together, they develop some resource, these are the infographics, and then in turn we use these within our nurse education. So it's a two-way process. They are spotting a need, they're generating a resource, and we then deliver that to our student nurses as a live resource that they use in their teaching. And then the next one, please, Tamina. And then the sort of final thing that we're starting to do this year is looking at co-production between a whole variety of different professional groups and service users. So we're running in our final year a series of bench to bedside workshops and seminars. We've picked out a few areas where we can really have some sort of impactful discussion. So we're looking at cancer and acute care and older adult care and a whole variety of different things. And then if you can pop the next one on for me, Tamina. And then just run through the animations. Perfect. So what we're going to do is bring together a whole variety of different people. So both the apprentices, we're going to bring together some researchers that are looking at that particular area in their current research. We're going to bring in some healthcare professionals. So that will be some of our nursing lecturer colleagues. We're going to bring maybe a bit of immersion and immersive learning in. So we're going to either get them into that ward space, Or, for example, for the older adult care, we're going to get them dressed in those sort of simulation suits so they can experience what it's like to be an older patient who can't manipulate and walk and see as well as they may have used to. And we're going to bring some service users in, and we're going to get them all in one space. We're going to let the student design their own outcome. So they're going to work out what their learning outcomes should be and work on an output for that. So it could be looking at some sort of gap analysis of what the research is showing as the new developments, and maybe reflecting on patient experience and developing maybe some learning material. It could be looking at how they might want to go back and redesign a service if they could. It could be looking at where they are now and where they could be in the future, and what they need to do to bridge that learning gap. It's a bit of a high risk one because we're going into it with absolutely no outcome. We're letting them design the whole process themselves. But actually, I think it's going to be really interesting because it, I made a note of your phrase earlier to me, that this culture of collaboration is exactly what we want them to be going into practice doing. We want them to be able to look at where the gaps are, work out who the best people are to have the most informed voice to help do that, and then be empowered to have those connections. And I think that's really what the intent of that HCPC standard that we set right at the start was. It's to do this. It's not just a tick box exercise to make things okay for a portfolio. It really is to build that culture of collaboration that will then see you through your professional practice in a way that can develop really impactful change. So there are just a few examples that we do, and some that Tamina do, does at Salford. I think it's important that, you know, these are just examples. There's a whole load of things that we could do, but it's starting that process that's really important. So I think, are we come to the end and looking for questions now, Tamina?
Yeah, really. Thanks, Ian. I was just going to mention, actually, it was a while ago, last year, I was on a course at the university, but we had program leads from all different professions, and it was really interesting because we had nursing program leads, but we had program leads from the police program, paramedics, forensics, those kind of things. And we actually got talking and discussed how it would be absolutely amazing if we could do a simulation where, for example, there was a crime or a murder or I don't know, and the police were involved, do a simulation in that sense, and then get emergency services involved, and then in a way where it all leads up to kind of samples being processed in the lab and that kind of thing. Exactly how it would happen in real life, but it would just be absolutely amazing to do something like that at university and get the students observing other roles that aren't just within healthcare, but, you know, things like law and the police. Yeah, we were getting really excited talking about something like this. Just something for the future, because these things do take a lot of planning. But I don't know, Ian, if you've had a chance to talk to other people about it.
We have, and we've sort of part of our simulation space now has been used by forensic students as well, and we've got a sort of simulated cell block and simulated crime scene and all of those things, and we're looking at it from the sort of chain of custody of samples. So sometimes, and I remember from practice being sort of on call in biochemistry late at night and the police knocking on the door demanding samples and not quite knowing what I should do or shouldn't do. So we're sort of simulating that sort of thing as well. So we can think about those, I suppose, those unexpected things, those things that you can't really train for unless you're in that space. So things like chain of custody, identification of samples, particularly if there is these sort of unexpected, unfamiliar circumstances that you don't often encounter. So yeah, absolutely, Tamina. Thanks,
Ian. So I hope that's been useful for everyone, depending on where you've come from, whether that's practice or academia, or even as a student, you know, understanding how different roles work together. I'm just going to end with this slide here before we take questions, because we're very proud to have won the award for Educational Institution of the Year, so both our universities, which is great. So just congratulations to us, really.
What a nice way to end.
Had to get in that.
And it's a lovely photo. So that's nice to have. So thank you both for explaining your examples. I think that's been really helpful for colleagues. I wonder if we just have a chat for a couple of minutes to give people time to think of questions. Everyone's been listening really intently. There's not been a lot happening in the chat because I think people have been thinking about what you're saying and kind of formulating things they might want to ask, or perhaps share experiences if other people have had a go at interdisciplinary teaching. So I'm just thinking about the students and their experience and their feedback. So the situations that you've already put them through, in a very positive way, not done it to them, but that they've been involved and they've had that experience. What kind of feedback have you had from the different groups of students about their experience and how it has helped them? Is it been positive received?
Yeah, so we've had a mixture of feedback from students in the sense that some of them, when we first trialled this, some of our students said they would love to go over to the simulation suite and actually be involved in that part where the nurses are taking blood. And we actually did that for the second time that we did this. So we put a call out to ask which students are interested in kind of physician's associate and going into kind of medicine. We thought that would be a good opportunity for them to observe. And the students in the lab, they absolutely loved observing how the nurses actually took blood from the patients, and the nurses also fed back that they don't realise what actually happens to those samples once they arrive in the lab. And I think it was really interesting for me, I think, coming into academia from the lab setting, because, you know, we've had phone calls all the time where we have nurses ring in the lab to ask, why has this sample not been processed yet? Or we would ring the nurses or the wards to let them know, oh, a sample hasn't been labelled correctly. So it was really interesting for them to see that side of things. And, you know, we've had feedback that it's good for them to be aware of these things that happen before they've even gone out into the workplace, because you wouldn't necessarily know what's happening to those samples unless you've been taught it or you've actually gone into a lab and observed those processes. We've generally had positive feedback for this, so that's why we've embedded it. But we are looking to expand it now, like I said, look at other areas. So that's embedded within our haematology and transfusion module, but actually it'd be nice to kind of include other areas and expand it out to other specialisms.
And have you had the same, Ian? Because I know when we visited Staffordshire, it's brilliant. You have the simulated wards, don't you? And that was definitely something that you had there as well.
It's there's two really important pieces of feedback, really. First of all, and the one thing that we were trying to do this originally, if you are in practice, going into a clinical space can be quite daunting because it's different. It's the same and different from a lab space, isn't it? But if you're going onto a sort of an acute clinical space, it can be quite an intimidating area to be in. You can be standing there and there's lots happening around you and there's lots of noise and there's lots of beeping and sounds and it's hot and all of those sort of things. So one of the aspects that we were quite keen on, that students actually felt comfortable in that area. So when they were in practice, they felt a little bit sort of more enabled to go into those spaces, which has worked quite well. So that's been quite useful feedback about that, preparing them for actually going into live spaces. The other thing that has been quite nice is feedback from the other professions. So that simulation where we had the nurses in the lab was brought up at their course committee meeting as an example that the students put forward a good practice. And we find that quite a lot. So I do a similar session with the operating department practitioner course. And again, student feedback is what keeps us going on that course. Because it's sometimes from an academic staff point of view, they will invite us in to do and to take that element, more so just to fill a slot on the timetable sometimes, but actually seeing that student feedback and realizing that they really appreciate it and value it, and they're talking about their examples that they've seen in practice. We use it for a lot of myth busting. We put a few people right of bad practice that they've seen on their placement and in their practice, but it's having that feedback loop going back through their course committees and encouraging more of this that's been really quite helpful as well.
And I think what you said about a high pressure, high stake environment and being able to experience that, where if it does go wrong, it's not the end of the world, it's not going to hurt anybody, and just feeling a little bit prepared maybe for that, but certainly raising awareness. Certainly we do find biomedical scientists tucked away in the bowels of a building, don't we? So other professions having more of an awareness of what happens and why it's important. I think what you've both said about, actually if we don't put enough blood in the tube, or if it isn't labelled correctly, or if it's torn or the wrong lid is on, why is it that somebody rings up and makes a fuss? I think it's really important, isn't it, like you say, for people even before they get onto the wards to understand why that's a problem or something that needs to be addressed. A couple of things have come in on the chat, haven't they, while we've just been talking. So Heber's asked about multidisciplinary team meetings. Have you got any simulations around that? I'm aware of one university that does a similar thing about a cancer patient journey, and they have an activity that the students can observe online. So they're doing a little bit around that. Have you done any of that yet, or is that in the planning?
We've got a plan for that. So we have a sort of a part of the integrated module that you mentioned earlier, Sue, as part of the accreditation framework. One of our integrated modules is case-based, and the intention is that the students present their findings as if they're presenting to an MDT meeting. What we haven't quite got yet is that full multidisciplinary panel. So they're presenting as if they are, but we would like some more input from other colleagues to either role play people from another team, possibly if we can't get those practitioners. So that's sort of developmental, but I think it is good because it can be difficult to access MDT meetings. I think you mentioned that earlier, Tamina. It's sometimes difficult to do, so simulating that would be quite useful.
Yeah. I think the question that Heber's asked is whether students can attend live MDT meetings to observe how doctors, pathologists, healthcare professionals collaborate to determine the best diagnosis and treatment plan for patients. So yes, students can attend. I think it just depends on the trust that you work in and how they facilitate that. But the trust I worked at, I had an opportunity to attend an MDT meeting when I did my placement many years ago, and I tried to do the same for my trainees that were coming in. Not every lab will do it, but some labs, if you present the idea to them, they might never have thought of it before, and actually once you've suggested it, it might become part of the training plan. But yeah, students are able to attend. I can see something related here as well, where someone's commented about an example where they verified a portfolio, and part of the evidence covered visits to theatres, and they were able to observe operations related to the tissue samples that they process in the lab. Which again, I think it's amazing to see that the process you've been part of, you've been able to go away and have a look at how you've been involved, even though it's in theatre, which you necessarily wouldn't have known about if you hadn't gone and experienced that. So yeah, those ideas, I think when they come through in portfolios, you just start thinking of ideas to share with other people. And
that's a really nice thing, isn't it, about looking at what other people do, is you get those really nice different things and you can bring them back. But it's one of the things that sometimes people say to me about the registration training portfolio. If they're a trainee or they're an apprentice or a student, they might not be patient facing, they might not see anybody outside of the lab. How do we get the service user patient bit in? And this is a really nice way to do it, isn't it? So all of those people that we've talked about today are service users of pathology laboratories. So maybe thinking a little bit outside the box. You don't need to spend a lot of training time. You could get students from other programs who are also on placement at the same time to talk to your students, couldn't you? And do it in that way and have a think about what service users, how might they be involved, what that might the interaction be, and that might be a nice way to do it.
Yeah, that's a good idea, Sue. Thanks. To think about that one. When I was doing my placement, I remember I had a week where my training officer had organised for me to go and visit the other labs. So I went to biochemistry because I did my placement in haematology. I went to genetics and I went into histology. I didn't last a long time in histology. I left within the first 15 minutes. I was just too squeamish. But they also allowed me to go into the chemotherapy area, sit with patients. I went to the wards. I did a ward round with a transfusion practitioner. So lots of areas that and I did the MDT meeting as well. So I think for training leads, if you can do something like that for the students when they come in to do their placement, or even for apprentices, that would be really good. There's a comment in the chat, or question rather, that Italica sends students to other labs to see different ways of working and look at the difference in work pace, turnaround times and things, but most of the time they don't know what to include in a reflection. Can universities help with this?
So self-reflection, yes, most university courses will have bits on self-reflection for students who are not even going on placement. It's normally part of the key skills and transferable skills that they should be being taught how to reflect. Maybe a bit of a framework about what kind of things you would want them to reflect on. So that could come from the hospital, it could come from the university. But if you talk to your placement tutor, I'm sure that you could come up with some ideas about what are the key things you want them to mention. but the ability to self-reflect is something that they should be taught, shouldn't they, in the first and second year before any student will be going on a placement. So yeah, that's something that they could definitely help with. But we have done support hubs previously, I think, on self-reflection, haven't we, Tamina? So we can maybe signpost people back to that.
Yeah, there's a guidance document as well on the IBMS site for reflection as well. And I think there's a template, a reflective writing template. So a few questions to prompt them to kind of get them started. It provides a bit of a framework. So what did you learn?
Sorry, Tamina. Yeah, sorry to interrupt. So basically, just to be very clear and to clarify what I'm actually asking. So students know how to reflect. That's not what I'm asking. It's just that when they come back, when they compile an evidence for the lab visits, it ends up as a repertoire for all the tests that are done in that section. And that's not the point of lab visits. The point is to understand similarities and differences. The point is to be able to see how different methods are used to identify the same disorder, or how the same skill, or how different same skill is used is applied very differently. So for example, ELISA assay can be used in almost all the disciplines, but to identify different conditions. So it's just to get an appreciation of this, to have a focus on this rather than just mention the test repertoire of each department. So this is something that if universities made clear, maybe it would be a bit helpful.
I think the thing is, if that's a piece of evidence for the portfolio, that's really the training officer that would be giving that advice. But Jim and I have had a conversation about this recently, actually, that people have been asking Jim, because he's looking after one file, about pieces of evidence and people not giving the evidence that's wanted or required. And sometimes it's the question is not that clear. So I think if you want them to compare how a particular technique is used in different laboratories to give different answers that helps with the patient diagnosis, then that's what you need to ask them to tell you. So if you just set them off and go and observe things in the lab, come back and tell me what you saw, that is what they're going to do.
Okay, yeah, fair enough.
I think just as a perhaps an example you could use for that is just use a bit of process mapping, sort of, because you talk about the differences in turnaround time and pace and things. So almost process map from pre-analytical, analytical, post-analytical, and annotate where the differences are, and then explain why those differences are. But as Sue says, I think it's being specific in what we're asking them to do. And giving a bit of a framework. Sometimes reflection can be then quite wide. So if you can sort of narrow down the actual context of that reflection specifically, I think will probably help.
Okay, thank you.
I can't see any more questions in the chat that have come in. Does anybody want to ask any question? Just unmute the mic. Has anybody been mulling things over while we've been talking? Has anyone else got any examples of where they've done interdisciplinary teaching activities that they want to share before we call the session today to a close? Hopefully people have got some useful ideas. I think it's been really interesting and useful. And actually, Ian was at the Academia SAP yesterday, weren't you, Ian? And we were talking about resources to share. And I think this might be a really nice example. We did mention yesterday, Tamina, about placement preparation, but also this kind of quite novel and unique thing that's really good practice to share. So it could be that we put it for academic colleagues, but also training officers as well, thinking about students when they're actually out on placement. If you're both up for that, we can have a look at creating some resources.
Yeah, I think it'd be nice to provide maybe a framework of different areas that students can visit, and training leads can pick and choose what will work for their trust. Every trust might not have the same kind of team or department. But yeah, I think for some of the specialist portfolio type of tests where not every trust performs a particular test, for example, we've had our staff go over to another trust to go and work there for a week, and they've sent theirs to us. And again, that's been really useful because they've been able to see how a different lab operates.
Yeah,
I think what might be useful, Sue, as well for both training officer colleagues and academic colleagues is this could be something to discuss at employee liaison meetings to sort of get a feel for how the universities do deliver it to students, but also where there might be possibilities to transfer that into practice, and where there could be some sort of collaboration there. I think that'd be quite a nice item on a ELM agenda at some point for people.
That's a really good point, Ian. So a lot of agenda items will be placements and how are they going, and then modules and who's teaching. but they tend to be the only fixed things. So yeah, maybe something about the evidence pieces and the interdisciplinary service users even might be a nice addition. That's a really good idea. Yes, we've got a question. Do you want to unmute your mic? Hopefully I've done it so you can unmute and you can just ask us your question. Is it Chuck William?
Yes, it is Chuck William. Hi. It wasn't actually a question, it was just higher. It was just a contribution to you know, this interdisciplinary collaboration, if you like. So I work in histology at Salford Royal, and we receive neuro specimens. So I was able to go to watch neurosurgery, which was really, really interesting. And most of the surgeries take quite a long amount of hours to perform, but it was just nice to be there to see the whole process, you know, to see what the patients go through as well, how long it takes, just the interaction between the nurses and, you know, the surgeons as well, the anesthetics. So that collaboration, it was just really good to see that, because I'm just in the lab and I'm not, you know, I'm not there when they do the surgery. So it was nice to actually go and see and appreciate, you know, that collaboration between the whole team. And so it was really good, because then we know where that, you know, how important that sample is, and that come from, you know, how long it's taken, the whole process, and, you know, also what the patient's gone through as well. So yeah, it was very enlightening for myself, and the whole team of people in the lab who also went to see the surgery. So just going to contribute that.
Lovely, thank you. I think that's a really nice observation, isn't it? It comes right back to what we said at the start about just understanding everybody's roles a little bit better. People understanding the role of biomedical scientists, but also us understanding, like you say, where the sample comes from, that it belongs to somebody that we always try never to lose sight of, don't we? Every sample is a patient. So yeah, I think any ideas that you have, if we are going to look at sharing some resources, if people have got other ideas and things they want to contribute, then please do get in touch, and we'll find an area to put them, and then we can disseminate that. I think that's been really good. So I'm aware we're at 1 o'clock, so I'm sure a couple of people have had to leave early for other meetings. So if you do need to go, please feel free to leave. Thank you again for joining us today. Hope you found it useful and enjoyable. I've certainly enjoyed it today. Thank you, Ian and Tamina, for your presentations. And please join us again in December. We've got a presentation about military activities of biomedical scientists. So we look forward to seeing you then. So thank you very much. Bye, everybody.
Thank you. Bye.
Bye, everyone. Thank you for joining.